Assalamu alaikum. Now I would like to discuss about acute leukemia, chronic leukemia and myeloproliferative disease in one setting. This is the picture of blasts of acute leukemia. This is the blasts of acute leukemia. Look at the nucleus. These nucleus look like punched out. There is punched out nucleoli in acute leukemia. Okay, in acute leukemia there is acute lymphoblastic leukemia, acute myeloblastic leukemia, acute monocytic leukemia. First of all, I would like to discuss about ALL, acute lymphoblastic leukemia. In acute lymphoblastic leukemia, what you have to remember that in acute lymphoblastic leukemia there is TDT positive. TDT, which is a DNA polymerase, it is positive in acute lymphoblastic leukemia. It is unique for this case because in other leukemias TDT is negative, only positive in acute lymphoblastic leukemia. This is one high yield point. And second, there is association with Down syndrome. It happens after the age of 5, and in acute megakaryocytic leukemia there is also association of Downs, but it happens before the age of 5. So in acute lymphoblastic leukemia there is association of Downs after the age of 5. On the other hand, in acute megakaryocytic leukemia there is association of Downs before the age of 5. And this ALL can be subdivided into B cell acute lymphoblastic leukemia and T cell acute lymphoblastic leukemia. In B cell acute lymphoblastic leukemia, what happens that in there is TDT positive, I have already said that, and there is and it expresses CD10, 19 and 20, and it has excellent prognosis to chemotherapy, but as it doesn't cross the blood-brain barrier and blood-testis barrier, that's why you have to give separately in those organs. Apart from that, chemotherapy works excellent. And there is 1221. There is 1221 in B cell acute lymphoblastic leukemia. There are two varieties, 1221 and 922. 1221 is good and it usually happens in children. On the other hand, 922, it usually happens in adult and it doesn't have good prognosis. And these are all about B cell acute lymphoblastic leukemia. In T cell acute lymphoblastic leukemia there is CD2 to CD8 association, and it usually presents at a mass like mediastinal mass or thymic mass, and that's why it is called small lymphocytic lymphoma. This is all about acute lymphoblastic leukemia. Now I am moving to this is called OR rods, and OR rods and myeloperoxidase present in acute myeloid leukemia. In acute myeloid leukemia there is presence of OR rod and MPO positive. In acute myeloid leukemia or myeloblastic leukemia there is neoplastic proliferation of the myeloblast, and we know that in bone marrow it has to be more than 20% myeloblast in the bone marrow. For being leukemia, all the cells like myeloblast or lymphoblast, it has to have 20% or more than 20% in the bone marrow. These cells should present more than 20% in the bone marrow, otherwise you cannot consider it as acute lymphoblastic or acute myeloblastic leukemia. The most common variety in acute myeloid leukemia is APL, acute promyelocytic leukemia. In acute promyelocytic leukemia, it involves CD15-17 translocation. CD15-17 translocation, that means it involves translocation of the retinoic acid receptor RAR receptor on chromosome 17 to chromosome 15. There is 15-17 translocation to what receptor? Translocation of RAR receptor, retinoic acid receptor, on chromosome 17 to chromosome 15, and RAR disrupts and blocks the maturation and promyelocyte accumulate. Abnormal promyelocyte accumulation causing abnormal promyelocyte content primary granules, and that increase the risk of DIC, and that's why you should give ATRA, all trans retinoic acid, which is a vitamin A derivatives. All trans retinoic acid, vitamin A derivatives, you have to give in this cancer. It is unique. You are giving in a cancer vitamin. People might gonna shock that you are giving vitamin to a cancer patient. Yes, this is the treatment, because it involves, it actually blocks the receptor of RAR. That's why I'm giving this. Acute monocytic leukemia. This is another picture of OR rods. This is another picture of OR rods, and this is called acute monocytic leukemia. And in acute monocytic leukemia, most important what you have to remember, that there is GAM infiltration. In acute monocytic leukemia, there is GAM infiltration. This is high yield, and in this case acute megakaryocytic, in acute megakaryocytic leukemia, I have already told you about the acute megakaryocytic leukemia. In acute megakaryocytic leukemia, there is association of Downs before the age of 5. And another thing you have to remember, that you have to differentiate from myelodysplastic syndrome to AML. In myelodysplastic syndrome, there is blast cell which is less than 20%. In myelodysplastic syndrome, there is blast cell less than 20%. On the other hand, in acute myeloblastic leukemia, there is blast cell more than 20%. This is high yield. Now I would like to discuss about chronic leukemia. This is the picture of chronic leukemia. This is smudge cell, and smudge cell present in chronic lymphocytic leukemia. Smudge cell present in chronic lymphocytic leukemia. In chronic lymphocytic leukemia, there is neoplastic proliferation of the naive B cell. Neoplastic proliferation of the naive B cell. And other two cases, like in hairy cell leukemia, this is a picture of hairy cell leukemia. This is the picture of hairy cell leukemia. This is another picture of hairy cell leukemia. In both cases, there is neoplastic proliferation of the mature B cell. If there is neoplastic proliferation of the naive B cell, it is called chronic lymphocytic leukemia. On the other hand, if there is neoplastic proliferation of mature B cell, it is called hairy cell leukemia. And also in hairy cell leukemia, okay, in chronic lymphocytic leukemia, there is neoplastic proliferation of the naive B cell. There is increased lymphocyte and smudge cell. This is one important point. And all you have to remember the complications, the high yield complication, as there is uh, naive B cell, so B cell is not, so there is no B cell, B cell is not active, there is no plasma cell, no antibody, so there is hypogammaglobulinemia, which is causing infection, and infection is most common cause of death. And another complication is there is antibody against the RBC, that's which is causing autoimmune hemolytic anemia. And there is also transformation to diffuse large cell lymphoma, which is called Richter transformation. How it happens? Because it carries the additional mutation and causing this B cell lymphoma. In hairy cell leukemia, this is the hairy cell leukemia. In hairy cell leukemia, what you have to remember, that there is neoplastic proliferation of the mature B cell. There is trap positive, tartar resistant acid phosphatase positive, and you can confirm by flow cytometry. And in here there is dry tap, and as a drug you have to show, this is one disease drug, this is cladribine is a ADA, adenosine deaminase receptor inhibitor, cladribine, adenosine deaminase receptor inhibitor. These are the things you have to remember in this case. This is another picture of hairy cell leukemia. Okay, another thing you have to remember, that there is neoplastic proliferation of the mature T cell. It is called adult T cell leukemia, or lymphoma. Adult T cell leukemia or lymphoma. It happens due to a virus HTLV1, human T cell lymphotrophic virus 1. This is the virus causing this. All you have to remember in this case, that there is a features like multiple myeloma plus rash, that means hypercalcemia, that means anemia, that means light lesion in the bone. Also there is rash. If you find a patient like this feature, then you can confirm it that he is suffering from adult T cell leukemia or lymphoma. Now last thing, that this is a picture of mycosis fungoides. This is a picture of mycosis fungoides. This is cerebriform nuclei. This is a picture of cerebriform nuclei. This is also the neoplastic proliferation of the mature T cell infiltrating the skin. If there is aggregation of neoplastic cell in the epidermis, it is called Portrier microabscess. If there is neoplastic proliferation of cerebriform, if there is a neoplastic proliferation of if there is aggregation of neoplastic cell in the epidermis, it is called Portrier microabscess, and cells can spread to involve the blood and causing this Sézary syndrome. This is Sézary syndrome. In Sézary syndrome, there is characteristic lymphocyte with cerebriform nuclei. This is the cerebriform nuclei. Now, this is the picture of CML, chronic myeloid leukemia. In chronic myeloid leukemia, there is neoplastic proliferation of the mature myeloid cell. In myeloproliferative disease, there is neoplastic proliferation of the myeloid lineage. All the cells are enhanced, but there is particular increasement of a particular cell. Like in chronic myeloid leukemia, there is neoplastic proliferation of the mature myeloid cells, especially granulocytes, and they are precursor. And what you have to remember, that in chronic myeloid leukemia, there is 922 translocation. It is called Philadelphia chromosome, and there is 922 translocation, which generates a BCR-ABL tyrosine kinase, BCR-ABL tyrosine kinase, and as a drug you have to give imatinib, nilotinib, dasatinib, which acts against the BCR-ABL tyrosine kinase. Splenomegaly is most common, and it can present as this CML can transform into AML or ALL. How? Because this CML can hit the hemopoietic stem cell. In hemopoietic stem cell, it has the ability to generate AML or ALL, both. It can generate both. That's why it may happen that CML can transfer into AML and ALL. How can you distinguish that this person has a CML or other leukemoid reaction? There are 3 points of differentiating this. One is 922 translocation, another is LAP, leukocyte alkaline, LAP low in cancer, in acute chronic lymphoid leukemia, in chronic myeloid in CML, LAP is low, there is 922 translocation, and there is increased basophilia. Other cells are also increased, but basophilia only increased in CML. That's why it is unique. Now another thing, that polycythemia vera. There is neoplastic proliferation of the myeloid lineage, especially RBC. There is JAK2 mutation in polycythemia vera, in essential thrombocythemia, and in myelofibrosis. In these 3 cases there is JAK2 mutation, so you have to remember this. And there is in polycythemia vera there is blurry vision, there is facial plethora, and there is a unique thing you have to remember, that the patient feels intense itching after bathing, because there is histamine release from mast cell. That's why there is intense itching. So you can do phlebotomy, and you can give a drug called hydroxyurea, which increases hemoglobin F. Hydroxyurea increase hemoglobin F. Without treatment, the patient may die within a year. Now, how can you distinguish from polycythemia to essential relative polycythemia and relative polycythemia? In polycythemia there is, in polycythemia vera there is EPO is decreased. In polycythemia, EPO is decreased. On the other hand, in reactive polycythemia, EPO is increased. In reactive polycythemia, if it is due to high altitude or any form of lung disease, there is EPO is increased. If there is ectopic EPO production, in that cases EPO is increased. On the other hand, in SaO2, if you think about SaO2, in polycythemia vera, SaO2 is normal. In reactive polycythemia, if it is due to lung disease, then SaO2 is low, decreased. In reactive polycythemia, if it is due to ectopic EPO production, in that case SaO2 is normal. Now this is the picture of the essential thrombocythemia. There is neoplastic proliferation of the myeloid lineage, mature myeloid lineage, especially platelets, and in here there is JAK2 mutation. Okay, it doesn't causes hyperuricemia or gout, because platelet has no purine degradation product. If it hasn't any purine degradative product, so it doesn't cause hyperuricemia or gout. Now myelofibrosis. In myelofibrosis, there is neoplastic proliferation of again mature myeloid cells, especially megakaryocyte, and megakaryocyte produce excess platelet derived growth factor, causing myelofibrosis. And in here there is splenomegaly due to extramedullary hematopoiesis. There is leukoerythroblastic cell. There is leukoerythroblastic cell. Sorry, there is leukoerythroblastic cell. There is leukoerythroblastic cell. This is another picture of myelofibrosis. There is a teardrop cell. You can see this is a picture of teardrop cell. Teardrop cell. There is leukoerythroblastic smear, that is teardrop cell. Leukoerythroblastic smear, nucleated RBC and immature granulocyte, and increased risk of infection, thrombosis and bleeding. And another thing you have to remember, if you find a patient who is having is having this essential thrombocyte feature, another thing you have to remember that he might in peripheral blood film, if you find that there is platelets is more, you have to think IDA also. This is the picture of myelofibrosis, and this is and the white one is the fat cell, and there is fibrosis. And that's all. Inshallah you will be benefited.